Fluid and Electrolytes IV unit for Iowa Lakes Community College. This is Martha Olson, Part 5. Our short peripheral catheters, most commonly over-the-needle catheters, are used for peripheral, but we do have the ability to use a scalp vein when we have a small infant where the scalp is the only place we can get an access. Our midline catheters are also a through-the-needle catheter. They're about 6 to 8 inches long. They're inserted into the antecubital fossa, and they're used for 1 to 4 week installation. These are your PICC lines that you will be getting more information on later, but I want to introduce it now so that you have an idea when you go to clinical that there are other types of more permanent or longer lasting IVs rather than just the 3-day peripheral. For the midline, again, we know that it's for a longer therapy. It's placed between the antecubital and the head of the clavicle. It's intended for IV therapy or other things, not to be given with caustic IV things like chemo or TPN through this type of IV. We use the basilic, the cephalic, or the median cubital veins. We prefer the basilic vein because it's larger and has a more straight path to be able to cannulate, and we do not want to use the side where patient has possibly had a mastectomy or has a dialysis or different graft through that site. When we look at the PICC line, a specially trained nurse, RN, is able to put these in. It's under sterile conditions because, as you can see, the tip of that catheter gets very close to the heart, and an infection into that would be very problematic for the client. The non-tunneling percutaneous central catheters, we call these central lines. They have 3 ports. The benefit of this is that you can run 3 different things. If you have 2 antibiotics and fluids, or nitro and 2 IVs, 3 things can go in that at one time because each one of the catheters comes out at a different place. Again, as you can see, these go in very close to the heart. It's a sterile technique to change the dressing. These are inserted by a surgeon in surgery and are removed by a surgeon. With these type of caths, we have these tunneled central catheters with names such as a Grosjean, a Hickman, a Boviac that are inserted in during surgery. Our small hospitals in this area typically do not insert them. Patients come back from Sioux Falls, Mayo with these types of catheters. And your implanted port is more of a permanent port. The part you see on the picture here goes under the skin. You can feel it. It's kind of squishy and soft, and when you put a Huber needle in, it cannulates it at that time. These are most often used for people that have long-term health problems, Crohn's or colitis, your cancer patient, people with irritable bowel, sometimes if they have lots of problems. The port is placed in the upper chest, usually on the left, and when you go to flush it, it's a once-a-month flush. So if they're not ill at the time, they can come into same-day care once a month and just have the nurses flush that to keep it patent. So that's a very big benefit for that type of port, to be able to have a once-a-month flush if it's not being accessed. This is the needle that's used for the implanted port, called the Huber needle. It sticks above the surface, and we have to put sterile 2x2s under it to kind of pad it, and then the clear opsite over the top with generous amounts of tape to help stabilize that type of needle. The dialysis catheter then, as you can see, goes in the forearm. It helps us to remove the blood to be able to go into the dialysis machine and used then to clean and filter and give it back to the person in that dialysis catheter again. Switching gears just a little bit, we look at the different types of medications that, as nurses, as RNs, we will administer via the IV that we have just started. When we look at IVs, we know we have what's called a piggyback or an intermittent infusion. Remember, intermittent means on and off. Like, I give an antibiotic and then I flush it, and then maybe 8 hours later we give the next antibiotic. So it's not something running all the time. The abbreviation is IVPB, IV piggyback, you'll see that, or a secondary. The IV push or bolus is having medication in a syringe. You cleanse the site, You flush the medication in and it, boom, it goes in very quickly. We give Lasix this way, we give morphine this way. All of our rescue drugs coming off the crash cart are given via IV push. With that, the seriousness is that the med's gone. If you decide you've made an error or gave it too quickly, you can't retract it. It's there. And then the continuous infusion is a larger amount of IV fluid that's given over hours or days to maintain a drug concentration or a larger volume of fluid to replace for fluid volume deficit. We need to keep an eye on the patient to look for drug incompatibilities, fluid overload, IV infiltration, all of those complications that can go with that. So your piggyback is always going to hang higher than the primary. You see the piggyback is on the left. It's the smaller 100 milliliter bag. It's initiated after you have the main primary going. It's the most common way that we give antibiotics. We give them every 8 hours. You can hang that bag. You have your tubing primed. It goes right into the primary tubing and into the patient for that amount of time that it's administered. Most of your antibiotics are given over an hour to 2.5 hours. And the reason we suspend it higher is because gravity pulls from the highest bag, and so we want that piggyback to go in. Your IV push is given over a specific amount of time, and that's where you're going to have to use your drug book to look that up to see how fast you can give it. Some need to be given very, very quickly. Adenosine is one. It has a half-life of about 45 seconds, and so you give adenosine as quickly as you can so that by the time it reaches the heart where we want it to work, it still has some half-life in it. IV furosemide or Lasix is given over 2 to 5 minutes, because if you would get confused and give it too quickly, it can cause 8th cranial nerve damage and loss of hearing and ototoxicity. We have to know if a drug is compatible with what is running in the main line or the primary IV, and that also would be information you find in your drug book. If the IV is not compatible, we have a couple of choices. We can start a second IV, or we can flush the main IV with normal saline, get the tubing cleared, give the med that we need to give IV push, flush again with normal saline to be able to clean that, and then go back to the primary. A continuous infusion, again, is given over several days if possible. We can give a very small dose of medication continuously as a TKO or to keep open. That volume is about 20 to 30 milliliters. The reason that we typically have a to keep open is not to give them fluids, because it really doesn't do much to help hydrate them, but if they have a PCA pump, they have to have an infusion running at the time. Your normal rate for an adult is 100 to 125. If we give a fluid bolus or challenge, it can be much higher than that, but that's for a very short period of time, just to try to get blood pressure, urine output improved. For your pediatric client, you need to use critical thinking as to how old they are, what size of an IV, and what will cause fluid overload or too much fluid for those pediatric patients. So don't be afraid to question that if you have a pediatric client and you think the rate is too quick. For our tubing, our primary tubing is usually a 10 to 20 drops per milliliter. The macro tubing is what we use. Micro tubing is very specific and exact with 60 drops per mil. That would be used in like a neonatal intensive care or perhaps a cardiac care unit where it had to be given very exact. Our secondary tubing is shorter and it piggybacks into the mainline IV to give us our antibiotics. We also can secondary in things like Cardizem or other IV drips. Your primary Y tubing has a filter in it, and that is used for blood administration. And then your volume controlled IV tubing is for pediatrics, and that is where we drop down the amount of fluid for the hour, and every hour it forces us to go look at the IV site and to drop down the next hour of fluid that they can get. The tubing change has been following the CDC recommendations, and when we look at the policy, it is changing because they are finding evidence-based practice is calling for it to be done more often than what we had been. Most hospitals, it's still the 3-day or 72 hours if it's a closed port. They feel that it doesn't have as high of risk for infection when that IV tubing is closed at all times except when you change the bag. The secondary sets we're changing every 24 hours because we hook and unhook them every time we give an antibiotic, and there's a higher risk for infection because we open that to air. Your central lines every 24 to 48 hours, and our blood tubing is only good for 1 or 2 units of blood, or at the end of 4 hours. Remember, blood is a protein and it will grow bacteria very easily, and so blood and blood tubing has a 4-hour maximum time because of the proteins in that. There are some things that we add on to the IVs. The stopcock is one that we use in surgery, and it allows the anesthesiologist to turn on or turn off, just like your garden hose or your faucet outside, when they are trying to give maybe a little more anesthetic, but yet they have the IV running. I don't use the stopcock on the floor. The IV extension tubing allows you, after that IV is done running as a continuous, perhaps the doctor says leave it in as a saline lock until they go home. The extension tubing then allows you to not have anything running, but you can flush it at the end of the port. So in lab you will be starting your IVs with the extension set on, just because most of your patients will need it, and it saves you one step of opening that IV site again. Filters are used for blood products or other things that might have contaminants in them. Blood is the most common. And then our needleless access devices are things where we are not using a direct needle, but it has a sharp port at the end, so that we can cannulate maybe a blunt plastic or lure lock type of situation. Our infusion pumps are different in most facilities. They have become like our cell phones. They have become smart pumps to where they will tell you how fast you need to run it. You can program it to say, I have vancomycin, so many milligrams, and it will kind of direct you or help as a secondary way of looking to see that you're infusing them at the correct rate. They're very accurate and safe, and so infusion pumps, in my career over 30 years, when I started nursing, we did not use IV pumps, perhaps a little bit if it was a patient in an intensive care unit. Today everybody has an infusion pump. The exception to that is maybe a patient in same-day surgery that's just getting a little more fluid after their IV or their surgical procedure. The pump in the front with the small buttons is the smart pump, and that's the one most commonly seen in the hospitals where you will be doing clinical. It's just one of those things that when you get to that facility for orientation, you will have to spend some time getting used to how to prime the tubing through that, shutting the door, hooking and unhooking, and then setting your pump up. When we get to the next part, we will be looking at IV fluid and the different types of fluids that we have. We will be looking at osmolarity and osmolality. But as we recap what we've covered so far, we know that IV has a lot of nursing judgment and responsibility, and as the nurse we have to decide where the IV is going, when it needs to come out because it's infiltrated or infected, and getting it placed in the right site for the person. We have many different sites besides just the peripheral IV, but as we progress on in the program, you will be learning more about those. So this will end part 4 of our voiceover on the IV and fluid and electrolyte unit.